And
Yes.
yeah, so today's webinar, we are going to look at cancer of the cervix. And Dr. Mokomba, who is a gynecologic oncologist, is going to be our presenter today. Dr. Mokomba is head of the Gyne Oncology Unit at KNH. He's a colleague, we work together. He's very passionate about gyne oncology and cervical cancer in particular. And so we are really going to have an interesting afternoon. The topic he's going to look at is wide cervical cancer. And so, you know, cervical cancer is a big and the leading cause of death related to gynecological malignancies and cancer in women in general. So we'll just look at an overview of the topic covering both the disease burden issues, risk factors, how do patients present, staging of the disease and treatment as highlighted on the screen. But more important also is to look at the prevention through screening and vaccination of women, because that is what we really want. We want to prevent the disease before it develops to the invasive stage. So, Dr. You're welcome. I would request that if you note something, post it on the chat box, and then at the end of the presentation, we will be able to respond to the issues that you raise. So you can share your screen, Daktari?
Yeah. I'll ask the guy of research to run for me. I think he has a copy, if he can.
Okay. Okay.
Yeah, I hope he's able to. He's able to run it. Are you able to run it for me?
Yeah, I think, Daktari, I can see your slide on the screen. So
okay.
you're probably ready to go, yeah.
Okay, so good afternoon, everybody. Yeah, like my colleague, Dr. Musali has stated, we are going to discuss about this gynecological cancer called cancer of the cervix. My name is Dr. Mokomba, as has been introduced. We'll go right. Yeah, next slide, please. Okay, yeah, in terms of the epidemiology, we know in our country it is the commonest gynecological malignancy that is afflicting our women, causing large morbidity, that is a lot of medical complications, as well as mortality. A good number of our patients who are on dialysis for kidney failure are as a result of the complications that result from cervical cancer. Now, worldwide, about 500,000 cases are diagnosed every year. 500,000 cases. Out of those, you have around 265 deaths annually, and those are the ones recorded. So if you can imagine one, Airbus Super Jumbo A380, about 500 people, you'll need to be crashing almost one every day to match this figure of 265,000. So it is that serious. It's like having, the large plane crash, one every day to achieve this mortality. So it's quite serious. In Kenya, the documented cases are about 6,000 cases annually, out of which we lose over half of them. So between 3,600 to 4,000 people die, women die every year in Kenya because of cancer of the cervix. And really, this is a tip of the iceberg, because a good number are not documented, they are not registered. So this represents only the figures that are available within our cancer registries. If you come to our wards, they are full of women with cervical cancer. For example, at the referral hospital, you'll find in the gynecology ward, almost 60% of it is patients admitted with complications of cervical cancer. So it's a major problem that we need to address. We know the most of the cases of invasive cervical cancer are peaked at around age 35 to 40. Then there's another peak that occurs between age 55 to 60. And that is as a result of the way cervical cancer starts after infection with the HPV virus, which is really the cause of cancer of the cervix. We know in specimens taken out of patients with cervical cancer, almost 99%, one would say up to 100% of the specimens have got this HPV virus. So next slide. Next slide, please. Okay. So to be able to understand this is because once one gets the HPV infection, which is really a sexually transmitted infection that is thought to affect 80% of all those who are sexually active, both male and female. And then once one gets infected, majority of these patients will clear the HPV virus from the system within 1 year. But for the few where the infection is persistent, then these are the ones where we have changes in the cervical epithelium, the cervical lining. We have changes we call dysplastic changes. So it starts slowly, you have mild changes. As you go along, then the changes become even more severe and distorts the architecture or the structure of the cervical cell. And eventually you end up with these cells becoming cancerous or malignant. And as it continues to grow, then you have invasive cervical cancer. So yeah, next slide. So what are the risk factors for developing cervical cancer? By and large, the risk factors revolve around infection with the HPV virus. Like I said, it's a sexually transmitted infection. So any sexual behaviors that will put one at risk of developing cervical cancer then will increase any risk behaviors that will be at risk of spreading the HPV virus will predispose one to the risk of developing cervical cancer. So those who have infected with high-risk HPV types, those who have multiple sexual partners, those who have a partner with multiple sexual partners, those who have never had cervical cancer screening, that is considered a very big risk because it is through screening where we are able to get those with the changes that occur before it becomes cancerous, and we are able to effect the correct management, which is not as expensive as when somebody has developed cancer. It's been shown those who have a high number of children, there is a slightly increased risk of developing cervical cancer, low socioeconomic status, because this revolves around the sexual practices. Those with partners who are, the male partner who has undergone circumcision, the risk reduces. Those who have not, the risk is high. Yeah, and those who have immunosuppression, especially as a result of HIV/AIDS, have been shown to be at a greater risk of developing invasive cervical cancer than the general population. Next slide, please. So in terms of how does this disease then present once it has occurred, the most important thing to note is that in early stages, cervical cancer is asymptomatic. There are no signs or symptoms at all in the very early stages. Signs and symptoms come as the disease advances. And that's why screening, again, is important, because we are able to pick this condition before it becomes advanced malignancy, or it changes to malignancy. It is when the disease advances is when we start having symptoms. And the most common is abnormal vaginal bleeding, especially contact bleeding after sexual intercourse. The lady notes that she's bleeding, or after douching, or if somebody carries something heavy, as one lifts, then one, because of the pressure effect, then one notices they are bleeding. Women who are already in the menopausal age group and they are bleeding, this is, again, can be a sign of development of cancer of the cervix. Then as the disease advances, then you get to the late symptoms, which include, again, bleeding, a foul-smelling vaginal discharge, and then pain comes as a late symptom when the disease now has spread to the surrounding organs to cause pain in the nerves. So somebody has a lot of lower abdominal pain, lower back pain, even leg pains as a result of the pressure symptoms. One can end up with pain when passing urine, blood in urine, that's hematuria, blood in stool, or one can end up with anal bleeding if the disease has invaded the rectum. When the disease has spread to other organs, you can have things like somebody with a chronic cough, with blood-stained sputum. One can end up with brain symptoms if the disease spreads to the brain, metastasis to the brain. And the more severe and common complication is when the cancerous growth compresses the ureters, which drain urine from the kidneys. Then one ends up with kidney failure. And as a result of the kidney failure, if there are no available facilities for dialysis, one ends up with uremia, which eventually takes the patient. The patients can also develop fistulas, either rectal fistula or a bladder vesicovaginal fistula with stool or urine incontinence as a result of invasion of these organs. Let's continue. Yeah, if that is not treated, then somebody ends up with chronic renal failure, and the patients will die of complications of kidney failure eventually. Fortunately, at least now we have fairly available dialysis facilities, so we are able to sustain these patients a bit longer. The next thing I'm looking at, just in general, is what is the pathological types of cervical cancer. Most times, in over 80% of cases, is what we call squamous cell carcinomas. And then between 10 to 20% will be adenocarcinomas. These are carcinomas arising from the glands within the cervical canal that will give adenocarcinomas. And then, but you can also get the rare types of cervical cancers like neuroendocrine carcinomas, carcinosarcoma, lymphomas, and melanoma. In terms of how the cancer looks like, this is what you get on physical examination, especially through speculum examination. You can have a growth that grows outwards from the cervix. It's called an exophytic lesion. You can have one that grows within the cervical tissue to form a barrel shape. And you can have an ulcerative lesion that forms a deep ulcer that bleeds a lot within the cervix. There is also a type that grows within the cervical wall and then follows the vaginal walls. It's what we call the infiltrative lesions of cervical cancer. Next slide. How do we make the diagnosis of cervical cancer? And this is very, very important because it's what we normally miss. For example, I'll give you a real case scenario of a patient we saw today who has been going to Siaya County Hospital for the last 2 years with bleeding, and nobody ever did a pelvic examination. And today, when she reached us on examination, finds she has a big cervical tumor that has really spread, that could easily have been picked at that initial facility where she prevented. So the emphasis was on all women who are bleeding or have an abnormal discharge must have, at the very minimum, a speculum examination, so that we are able to assess with the naked eye how the cervix is, how the vaginal walls are, and if there is any ulceration or any tumor growth, we can be able to detect that. So I cannot overemphasize that enough. You can do all the images that are available, but if you have not done a speculum examination on a woman with abnormal bleeding or abnormal discharge, then that woman has had incomplete assessment. Because with just merely this, we'll be able to pick early cases of cervical cancer. We'll be able to pick changes that are suspicious, then we are able to do the necessary screening stages. Not that imaging, whether MRI or CT scan, will only pick these cervical tumors when they are big. When they are starting at the very early stages, it's less than 0.5 centimeters, or it's even microscopic. Imaging will not pick. So it is a cry for our institutions, that especially the public institutions, let's provide these basic tools so that the clinicians can be able to do proper examinations. A disposable speculum is about 50 shillings. That 50 shillings can save thousands and thousands of money for these patients who later will end up with advanced cancer, which we could have picked early. Next. So one detects a cervical lesion, a cervical tumor. What is the next step? If it's just, for example, inflammatory changes within the cervix and no obvious lesion, then one will do colposcopy, where we use a microscope to examine the cervix and take a biopsy for histological analysis. But if there is an obvious lesion, then what we recommend is what we call examination under anesthesia. Examination and anesthesia. The patient is put under anesthesia, then we are able to examine without causing discomfort or pain to the patient. So we do examine the entire genitalia, then do put a speculum, look at the and once one identifies the lesion, then you take a biopsy for histology. After that, then one can do a digital exam to evaluate the vaginal walls, the adnexia, and then do a rectovaginal exam for assessment of the rectovaginal mucosa or septum to see whether there is any cancerous or any involvement of that part of the body. The other additional examinations one can do under anesthesia is cystoscopy, where one is able to view inside the urinary bladder, can do a colonoscopy to check for any lesions within the rectum. Remember, rectal cancer is associated with HPV, so one should be able to rule this one out as well, because we have seen patients who come with both rectal and cervical cancer. So with this, then it will have given you a complete assessment of where one is, and one can do a clinical staging. Next. Yeah, that's just an illustration of how the examination should be done to when one is assessing for any possible lesion during EUA. Let's continue. Next slide, please. Now, imaging comes in now to augment the clinical findings. And what we do recommend is a magnetic resonance imaging, MRI, because it best delineates a soft tissue. Therefore, with the MRI, we are able to see whether there is involvement of the bladder wall, involvement of the rectal wall, and it's also able to tell us whether there is a lymph node, whether the pelvic lymph nodes especially are enlarged or not. Where MRI is not available, one can still do a CT scan. We can do a chest X-ray to rule out any chest metastasis, or a CT scan of the chest where there's suspicion. Now that we are getting availability of PET scans at Aga Khan University Hospital and Kenyatta University Hospital, where it is necessary, we can as well do a PET scan for a complete metastatic workup. One hopes in future this will be more available and more cost effective so that we are able to stage the patients in a more complete way. Next slide, just skip that. Next one. Okay, the next one, that's just the histology appearance. I think that we can look at it later. And next one again, let's skip that. Yeah, that's the image of how, that's the image of how a cervix with a cervical tumor looks like. We can have the next one. I think we had looked at this. Next slide again. Okay, even this we had mentioned it. Let's go to the next one. Almost done. Yeah, the next thing is about staging, because staging of cervical tumors determines the type of management. Yeah, determines the type of management. So if it's stage one is when the disease is confined to the cervix. And then there are sub-stages under that. Stage 2 is when the disease involves the cervix and the upper 1/3 of the vaginal walls. Then stage 3 is when there is involvement of the lower and the pelvic side walls. Then stage 4 is when there is involvement of the bladder or rectum, and then 4B that describes when there is involvement of distant organs like the liver or the lungs. So there are various breakdowns, and this is readily available. In the which one can download on Google for those with Android phones or iPhones. Next slide, please. Yeah, this describes the various stages like I was explaining. So you'll find like at stage 1A, you cannot see any obvious lesions. If you look at diagram B, now you're having a microscopic lesion still at stage 1. If you look at C, you have a big lesion, but it's not involving the pelvic wall. That will qualify as 1B, and 1B as 1B1, 2, 3. But if you look at diagram D, that yellow marking, it has got involvement of both the cervix and the upper vaginal walls. Next slide, please. Yeah, that is another view of the same, how the cancer spreads. You can see the surrounding organs. Anterior is the bladder, then the pink structure is the uterus, then posterior you have the rectum. You can see how close these organs are, hence explains how the pattern of spread goes. Let's go. Next one. Yeah, still an illustration of how extensive it can be. You can see, for example, figure F, how the tumor has grown through the vaginal walls to involve up to the lower third. You can see how at H, it has grown to involve the urinary bladder. Okay, let's go to the next one. It's a big topic, that's why I'm doing an overview. Next one. The next slide, please. So other investigations one can do, and these are really for supportive care or in preparation for the actual management. You need to assess the blood parameters, the kidney parameters, how well the liver is functioning, as well as the imaging tests that I had alluded to earlier. Next slide. Yeah, now to the most critical, that's how do we manage patients with invasive cervical cancer? If we catch it early on colposcopy, when there's no microscopic lesion, then we find changes that are almost transiting into obvious cancer, what we call carcinoma in situ. These patients can benefit from what we call large loop electrosurgical excision LEEP, or conization, where we remove the distal 1/3 of the cervix. Next slide. So like I said, management depends on the stage. So if we catch this disease at the very early beginning, when it's stage 1A1, where the disease is microscopic, then one can have just a simple hysterectomy, or for those desiring fertility, they can be done what we call trachelectomy, that's removal of only the cervix. If it's stage a little bit advanced at stage 1A2 to 1B2, so the tumor is still confined within the cervix, then we do a radical hysterectomy plus pelvic lymph node dissection. And yeah, those are the pelvic nodes, the parailiac nodes, obturator nodes, and paracervical nodes. And we give complementary treatment depending on the pathological findings. For example, if the lymph nodes are positive after analysis, then one can give complementary chemoradiation. Next slide. Next slide, please. Yeah, for those, no, the previous one. The previous one, please. Yes, that one. Patients with stage 1B3, where the tumor is very, very big, most times we recommend chemoradiation. And stage 1, 2A1, one can either do radical hysterectomy plus pelvic lymph node dissection, or send the patient for radiotherapy straight away. But of more importance to note is that patients with stage 2A2 all the way to stage 4, these patients are not amenable to surgery, and the recommended treatment is chemotherapy and radiotherapy. Of course, those with advanced stage 4B, that's distant metastasis, they respond better to radiotherapy and palliative chemotherapy. And last not least, in terms of the management, sometimes these patients are put on palliative care, where the tumor spread and the intent of treatment is not for cure, but it's just to make the patient comfortable. Yeah, so those are the ones we give palliative care. Take care of their pain, take care of their nutrition, take care of their dialysis, do urinary diversions. Sometimes some have to have colostomies, and psychosocial support. Yeah, next. So the other difficult patients are those with recurrent tumors. These are the ones that occur after initial treatment. And the options available is palliative chemotherapy. And also for those with small tumors that are centralized and meet the criteria, we do radical surgery called pelvic exenteration, where one clears all the pelvic organs and ends up with a ureteric stoma and a colostomy for those with who meet that particular criteria. In terms of chemotherapy, there are those usual chemotherapy agents we use. There's benefit with the newer drugs, the immunotherapy drugs, but they are very expensive, and NHIF does not pay for their costs. So I think I'll end it there and then welcome questions. Sorry, there's one last one, and it's very important. That last one, the best way of managing cervical cancer is prevention. It is inexpensive and is doable because this is one of the rare cancers which we can prevent through various means, and we can catch it early. So safe sex practices to avoid infections with HPV, delaying age of sexual debut so that our girls do not get HPV before they are mature and they are unable to clear it from the system. Screening methods, pap smears, HPV screening, and visual inspection with acetic acid and glucose iodine. And the other most important preventive tool is vaccination. Vaccination against HPV. Now we have available various medicines for vaccination that are safe and have been used for a long time. There's the one called Cervix, which is bivalent from GSK, and there's one called Gardasil, which is nanovalent. It protects against 9 variants of the HPV virus, and this is the one that is available in government centers for girls, from young girls from age 10 onwards, and it's given free of charge so that we're able to prevent them getting HPV in the first place. So vaccination plays a very important role. It is safe, and the rationale for giving it early is that because immunization works best if you give it before onset of disease. Yeah, Dr. Musale, we can entertain questions and clarifications.
Thank you so much, Dr. Mokomba.
Yeah.
That was a very good presentation. I'm happy. I thought you're going to take almost an hour and a half looking at the scope of the topic we're dealing with today, but you have done very well and managed to compress a lot of content within just less than 30 minutes, because I think we started around the 10 past. So that was very good. I've seen from the audience that some people are having a bit of challenges with viewing the screen. I think for those who had that challenge, it may be internet on your side, but generally, I think the slides were visible from my end. And I think even the person who was scrolling did a beautiful job keeping at pace with the presenter. So I think it's time for us to probably look at questions and queries. So I'll say this is a broad topic again. We've looked at the epidemiology. We've noted that cervical cancer is the commonest gynecological malignancy and the leading cause of cancer death among women. Dr. has also looked at the risk factor, the major one being HPV, and the fact that HPV is a sexually transmitted disease. So all the risk factors associated with STI transmission are also associated with the HPV transmission. Then we looked at how this disease presents, and he mentioned that abnormal vaginal bleeding is the commonest symptom. And I must add at this point what he emphasized, that when it comes to women who present with abnormal bleeding or discharge, we should do a speculum exam. The challenge, I think, has been that we tend to prescribe without examining and also image without examining. So you find a woman has some bleeding, but you'll send for an ultrasound without doing a speculum exam. And Dr. emphasized that a lot, that imaging should only be complementary after you've done a good pelvic examination. Then he looked at staging and the management, which is basically surgery plus radiation based on the stage. And to sum it up, we looked at the prevention of this disease, and he has emphasized that vaccination has a big role. Basically, actually, when you look at it globally, many countries have been able to reduce the burden of cervical cancer disease. And the strategy they have employed is vaccinating young girls. Say that if you go to countries like Australia, they rarely see patients with cervical cancer. But as here, we still have vaccine hesitancy, and we are not doing effective screening. So we are seeing a lot of these patients. As I told you, if you come to our gyn-oncology clinic, the majority of the patients we see have cervical cancer. So we look at the question and answer box. And Dr. I don't know whether you're able to look at that. I think I can see somebody there, anonymous, great topic. Looking forward to presentation. Where can one get HPV vaccine in Nairobi? So Dr. you'll probably respond to that, and how much does it cost?
For the younger girls, it's available in all government hospitals. And it's
yes.
for the young girls from age 10 to around 15, it's available for free. Also, one can get it at the private wing clinic KNH. I think it goes about 3,800 a dose for the Cervix vaccine. One can also get it in individual gynecology consultancy clinics. Most of the gynecologists will be able to get you the vaccine.
Okay, so there's another question there. When is the age, the peak age for this disease?
Like I said, between 35, 40, and then a second peak at around 60 years.
Comment about cervicitis and cervical cancer.
Yeah, cervicitis is an infection of the cervix, mostly with mixed agents. And why it will put somebody at a greater risk is because the cervix becomes inflamed and therefore amenable to easy infection with virus particles. So if it's a recurrent thing, then one gets into contact with somebody who has HPV, it's very easy to get these HPV infections. And yeah, if the HPV infection then is persistent, then the risk of developing cervical cancer from that comes in.
Okay, there's a question there, Choreocarcinoma, invading the cervix. I think this is mixing two topics of choreo, and here we were looking at cervical cancer specifically. So maybe that one we can skip. Can VIA really be used for women above the age of 50?
Yes, it can be used.
Can vaccination be done to someone above the age of 25?
Yeah, there's what we call the catch-up vaccines. But for these older women, then we recommend they at least screen for cancer of the cervix. They do a pap smear, and where possible, they can even do the HPV screening, because if you have cancer, then the vaccine will not be useful. Those now where the results are negative can benefit from getting the HPV vaccines.
How frequent can one go for cervical cancer screening?
Yeah, initially we advise you have it annually. If you have 3 tests that are negative, then after that you can do it every 3 years. But initially, do the first 3 every year. If they are normal, then one can now space it a bit longer.
How long does it take for cervical cancer to progress to advanced stage? I don't know what, but probably maybe you can talk about it in terms of pre-malignant lesion to cervical cancer, and then
from the time one gets infected with HPV to develop frank cancer, it can take between 5 to 10 years, depending on the immunity of the person. But there are people who that can develop a bit faster. It's not for everybody, but in general. So it takes a long time. That's why if we do screening and proper examinations, we're able to get these conditions before they develop into advanced cancer. So there's a long latency period.
Yes. Now, once you have cancer, the changes between the stages can occur very rapidly.
Yes.
Yeah. So it just depends on the cancer type, the cell types that you're dealing with at that particular time. Good presentation. Is there a relation between HIV and cervical cancer? I think that one was mentioned.
Yeah,
The question about getting vaccination around the age of 30. I think that one was also discussed in terms of catch-up vaccination. Can women over age 14 receive Gardasil? I think that is repetition of the same thing.
Yeah.
What are the measures to be taken if one has acquired HPV to prevent one from getting cancer? Maybe you can respond to that.
HPV itself does not have specific treatment, but those who are found to have HPV infection, then we do more closely scheduled screening tests.
Yes.
Especially pap smears and colposcopies, so that if the infection persists and there is a change in the cells, we are able to pick it early.
Very good. And also just to note that if the infection is there, majority, as he mentioned, will clear spontaneously, almost 90%, but 10% persist. How available is HPV in public hospitals? I think this has been noted. I think, again, maybe for the program managers who are attending, the information needs to go out to the public that the vaccine is available in most of the public hospitals. Please give us a brief outline on screening recommendation protocols in Kenya. I think that has been answered. Maybe I think, Dr. what you can mention something small here is with regard to VIA-VILI screening. Because cytology, you said every 3 years. What about HP and VIA-VILI?
Because VI is a cheap method of especially doing mass screening, because you only need a trained person. You do not need a cytologist, but then you are able to pick those with abnormal lesions on VIA-VILI. Those are now the ones who are forwarded for colposcopy and biopsy and histology. So I think it should be done with the same frequency, just like for pap smears, because it's a screening method.
Thank you. Comment, guidelines screening in HIV positive. I think probably some variation there.
Yeah, I don't think, so long as one is immunocompetent and does not have HPV infection.
Hello?
Benefit.
We are looking. Yes.
Sorry, I got interrupted. Even those who are HIV positive, so long as they do not have an active infection and they do not have cancer of the cervix, they can benefit from vaccination so long as they are within the recommended age groups.
Yeah, I think Cervix recommended to HIV positive patients. True, yeah. Screening guidelines in HIV positive patients. Maybe just a variation. So
it's a variation of the same.
Yeah, but this is annual screening. If you're HIV positive, screening is annual, yeah.
Oh, yeah. The screening is more frequent because the risk is higher.
Yeah. Vaccination for HPV is done from 10 years. I think this is a repetition. People asking the cut-off ages. How often do we do pap smears? That we have said.
Yeah.
How best can I support a palliative care patient who is HIV positive, has pap smears yearly, but still complains of painful coitus and false smelling perineal area? I think this patient needs a gyne review.
Yes.
So you send to a gynecologist to see. How can you treat one that has been answered? Scroll down. I don't know whether we have any more. What is the current regimen for treating cervical cancer? That has been discussed in the presentation. If you didn't listen, we said cervical cancer is either treated by surgery or pelvic radiation, depending on the stage. Age cutoff for Vili, I think that one we have discussed. Maybe Dr. for screening, cutoff age, when do we stop screening?
Yeah, of course, we should start with, for those who are sexually active, they should start having their screening. For the upper age groups, because we are seeing women as old as 80 years with cancer of the cervix. I think we should continue screening.
Yeah,
I've seen 80-something year olds with CS cervix, so I would
the
continue.
Guidelines. Yeah. The guidelines are if you reach probably the age of 70 and you don't have positive HPV, you can stop. I mean, 70, But remember, guideline just remains a guideline. People have different behaviors. There are some people who may become sexually active in old age than they were in the younger groups. Since you've seen some elderly women getting married to young people on social media and other platforms. So you need to individualize your guideline to the patient that you're dealing with. HPV is sexually transmitted and causes cervical cancer. Can it also cause throat cancer, Daktari?
Yes, it causes. HPV is responsible for vulvar cancer, cervical cancer, vaginal wall cancer. It can cause anorectal cancer and throat cancer.
Okay, somebody, Martin Macau, is asking, HPV current vaccine guidelines, is it beneficial to vaccinate both males and females?
Yes, if finances were to allow, yes, that would be ideal.
Sure. Okay. There's somebody called Jedida. Very good presentation. Thank you. Why can't the HPV vaccine be given to older women who have not contracted the virus before?
Yeah, like we said, there are catch-up vaccines, but the older one gets, then the vaccine becomes less effective. But even older women than the age group that is being given can be given catch-up vaccines.
Yes, so I think, Jedida, the issue is when you get vaccinated, we expect your immune system to produce antibodies. And so the older you get, the less responsive is your body's immunity in terms of mounting an effective response to the vaccine. So that is why we taper off as you get older. What age group is to get HPV vaccine? That's a repetition of the same question. What are your thoughts about hysterectomy as a preventive strategy for cervical cancer, Dr.?
No, we do not do it as a preventive. We can do the pap smears, which I remember surgery has its own complications. So we cannot do hysterectomy as a preventive measure, no.
They are simpler preventive strategies. Cervical cancer and contraceptives. Can you respond to that?
The link between oral contraceptives and cervical cancer is so indirect and actually not that proven. So it's an indirect, as you use estrogen-containing drugs, then there's proliferation of the cervical epithelial cells that probably are more amenable to infection with HPV. But the linkage is indirect, and I wouldn't really take it as a critical risk factor. The benefits of using the contraceptives outweigh any risk, if at all there are any, of using the contraceptives.
Yeah, so true that sexual behavior is more important than the use of the contraceptive. There's something here. Thank you for the presentation. I wish this came earlier for me. I have a sister currently in advanced stage. If cancer is diagnosed at a late stage, how can we tell the origin of the cancer is the cervix? Right now, the doctors say her uterus is frozen. Okay.
Through examination by the relevant doctors, gynecologists or gynecologists. can do an assessment and be able to tell where the cancer probably originated from.
Yes, that is true. And then now, of course, the treatment, as Dr. said, the more advanced the disease, there is not, the response to treatment may be partial. So you find if you're getting radiation, there's still some tumor even after radiation, and then now you will need to get palliative care. How can I identify a male patient with HPV? This is quite strange. Can you identify a male patient with HPV?
Yeah, you can do swabs and take it to the lab. The labs that do HPV testing, I guess they'll be able to pick it up.
Yeah, so you can swab and then test for HPV. I think the challenge I need to point out at this point in this conversation, when we are dealing with HPV, there is a stigma associated with the fact that it is an STI. And sometimes this becomes a barrier both to the screening and the testing. Say that some people fear if I go for the screening, say if you're a woman, just the same way we get discordant couples and the like. So sometimes the question is, where did it come from? But I think from a gynecology perspective, we are not usually keen to emphasize the STI bit of it. Say, if you screen a woman, do you want to check the wife again? I mean, the husband, and vice versa. So we more or less concentrate on the management of the lesion found after screening rather than looking at it strictly in the lens of an STI. Is parity a risk factor for cervical cancer? Dr.
Almost done.
Okay.
Yeah,
yes,
we say multiparity increases the risk a bit because with the repeated abrasions of the external cervix.
Okay, thank you so much. So I think this was a very interesting.
That gives a larger area that is inflamed, that is prone to HPV infection. So it's an indirect risk.
Okay. So that I think is the last question. I think from the question.
Before we go,
yes.
my hand has been up.
Okay. I think I was concentrating on the questions. Yes.
Yes. My name is Dr. Dismas Ongore. I'm a public health physician, and I have a special interest in cervical cancer.
Yes.
And I was shocked that you crash a jumbo jet daily. That is the magnitude of this problem.
Yes.
Yes. Mine is more like a comment. 2 comments. First of all, HPV vaccine is now available in the schedule. It is available in the immunization schedule for 10-year-old. So it's available in all health facilities as part of the immunization schedule. The problem has been low uptake. So that's a problem that you gynecologists may have to think about together with us, public health, how to improve the uptake of HPV vaccines.
Yes.
The other comment is about the screening. One of the risk factor you mentioned was infrequent screening and lack of screening. I was hoping that you'd say a little bit more about screening, but the problem with screening as it stands now, pap smear, the uptake again is very low.
Yes.
I think it's less than. No, let me just make my comment.
Yes.
It is less than 16% uptake of pap smear.
Yes.
So this is something that we need to think about. How do we improve the uptake of that? Because by the time you diagnose, it is diagnosed. I think for me, the key really is in screening.
That's true. That's true.
Yeah, so if we can think about how to improve the uptake of screening, I don't have the answer, but I think the pap smear and so on, these are very invasive speculum, older women being examined by younger clinicians and so on. So this is an area that we need to invest a little bit more on. How do we improve the uptake? Because by the time you diagnose, it's already past. Prognosis is poor. Really, the key really is when it is still in situ and we screen. So as I said, I didn't have a question. I just had a comment about those two. But otherwise, this is very informative, and I hope we will invest more time in screening. Thank you.
Thank you so much.
Yeah.
Yeah. I think probably our time is over. And so I think we go back to the host, KNH Research Department. But before that, we can thank Dr. Mokomba for a very nicely done presentation and for availing himself. I think you have discussed a topic with lots of public interest. And so we'll continue with this series as scheduled, looking at gyne malignancies in our next week's presentation. Thank you so much.
Thank you.
Back to host.
So we have quite a lot of work to do in this, especially screening, like Dr. Angore emphasized. Thank you.
Yeah,
I think we can end it there now.